and teen congenital heart disease program at Children's Hospital and the University of Colorado Hospital. He's board certified in adult cardiology, pediatric cardiology, and adult congenital heart disease. I've found his insights into COVID-19 fascinating, insightful, and most of all, helpful. And I hope you will too. So Dr. Kay, it's all yours.
Thank you for that kind introduction. See if I can share slides. Okay, can everybody see the slides? Okay. Well, last week I was invited to give a talk to our local community church that I belong to at St. Luke's Episcopal regarding just facts about COVID-19. I found we were all getting inundated with lots of media information, and it was a little bit confusing, sometimes conflicting. And even information we were getting at the hospitals, both Children's University and the University of Colorado School of Medicine, sometimes were conflicting with each other. So I thought it would be useful to try to make sense of the data that we have so far, so people are better educated, know why this social distancing is so important right now, and just what are the numbers that we learn really from China, Italy, and now the US. A couple disclosures, as we are always required as School of Medicine faculty to have disclosures. I have no financial disclosures, but I want to be clear that I am not an infectious disease expert, nor am I a pulmonary critical care physician who's currently on the front line of taking care of our local patients. To date, I have not cared for any of the SARS-CoV infected patients, but I suspect that will probably change in the next few weeks. So what are the updates? This is an update that I got yesterday in my email that I thought was fairly useful. And as I mentioned, this changes. We get updates like every 6 to 12 hours on this. So as of last night, there was 932,605 COVID confirmed cases with 46,809 deaths. That's about 19% mortality, which we don't think is the true mortality. Just keep in mind, when we look at numbers like this, many countries, particularly our own, when we started seeing cases regionally, are not able to test patients who we think have more mild disease. So this is going to be very biased worldwide to those that have more severe disease. In the US, as of last night, we had 213,000 cases, 371, with 4,757 deaths. In Colorado, we had 3,342 cases with 80 deaths, and 11 were reported yesterday. I just heard from one of my colleagues that one of our patients just died today at University Hospital as well. He was elderly with many comorbidities. Some of the predictions are that we expect this, what we call surge or peak, excuse me, don't cough in your hand, cough in your elbow, to occur around the 17th of this month. Although that we're not sure if the social distancing that's been mandated is going to change that and push that out further, which it might. But with that, we are fearful that we may have a shortage of 3,700 hospital beds to care for that surge, and a shortage of about 750 ICU beds. Perhaps not as bad as New York, but similar to New York. So we're clearly worried. For those that want to have an update on the daily Colorado numbers, you can go to COVID-19 Colorado Gov, and it gives you the daily case data. So a couple facts we've learned in February about how this virus works. It remains stable in aerosolized form for at least 3 hours in testing, perhaps longer. We know that it remains stable for up to and perhaps slightly longer, 24 hours on cardboard surfaces, such as cereal boxes and other boxes from the grocery store, and remains stable on plastic and stainless steel for up to 3 days, again, potentially a little bit longer. The median incubation time from exposure of someone who then gets the infection is about 4 to 5 days. And that's why this infection and this pandemic is so significant, because many, and actually most, will likely be contagious before the symptoms occur. Most people who have the infection will get their symptoms by 11 and a half days after exposure. So if we think about it, if you had exposure to somebody, if you're about 2 weeks out, it's likely that you didn't get infected. Well, what are the symptoms? Well, they're the symptoms of the common flu or other seasonal viruses, which are still in full gear in our community. About 88% will have fever at some point during the illness, but as much as 50% don't have fevers yet from the time they develop respiratory symptoms that may require them present to the hospital. About 68% will develop a dry, non-productive cough, but occasionally a productive cough with sputum will occur as well. A smaller number will have rhinorrhea or runny nose symptoms, and a few, up to 15%, will have gastrointestinal symptoms such as nausea, abdominal pain, or diarrhea. It also has been noted that the virus can be found in urine and in stool. So that is a potential source of transmission as well. When we looked at China, about 81% of the people who were infected had very mild symptoms and didn't require hospitalization. So that's the good news. About 14% developed severe respiratory symptoms. Really what we found out on x-rays and CAT scans is a viral pneumonia with occasionally secondary bacterial pneumonia co-infection. The symptoms are mainly shortness of breath and respiratory rates that we consider fast above 30 breaths per minute. And at sea level, they define this as saturations less than 93%, but at our elevation in Denver, many folks are at rest, and so we consider below 90% a more telltale sign. About 5% developed critical disease requiring what we call high flow oxygen or mechanical intubation and placed on a ventilator, or in some cases, extracorporeal mechanical oxygenation, otherwise known as ECMO. So when we look at what many of us are worried about is the case fatality rate, otherwise known as the CFR, those who get symptoms, about 1.4% was the case fatality rate. And this is based on over 1,000 patients studied in China. When we compare that to the influenza infection in modern times, the case fatality rate is about 10 times lower at about 0.1%. So this does seem to be, for reasons we're just starting to understand, more severe than the influenza infection. When we compare this to the previous coronavirus infection called SARS, that had a much higher fatality rate, but it didn't spread as bad as this one, and that had about a 10% mortality. In China, the case fatality rate was about 4%, but it was more than double that in Italy. And that was surprising considering Italy is a first world nation, but it's believed by many experts there in Italy and around the world that that's mostly because of the older age of the population in Italy compared to Hunan province in China, where about a quarter to a third of the population of Italy is above 65 years of age. In Iran, there was a slightly lower case fatality rate of 7.5%. In South Korea, a much lower fatality rate of 1.2%. And in the United States, as of yesterday, our case fatality rate was about 2.2%. In Colorado, it's very similar to the rest of the United States, of about 2.4%. So we do know some risk factors for who's going to get more sick and potentially not survive this infection. Young kids seem to be well protected. There's only a few case reports of children less than 15 dying from this, and most of them have had other chronic medical illnesses or were newborns, so much more vulnerable. But very, very few kids get severe illnesses where they require admission, and extraordinarily few die. So it's less than 1% for those that are 50 years and older, or up to 50 years of age. That increases to 1 to 3% if you're 50 to 59, and increases significantly more each 10 years, about 3.6% for those age 60 to 69, and 8% age 80 to 79. Excuse the percentage signs I accidentally added. And about 15% for those above 80. However, we have seen those that require ICU admission, mortality is almost 50%. Other risk factors for more severe disease and possible death from this are medical comorbidities. What are those? Well, we consider those any other medical problem that you're receiving treatment for, such as high blood pressure, otherwise known as hypertension, chronic heart conditions, chronic lung conditions, diabetes, cancer. So those with no medical comorbidities, it was less than 1% mortality. However, those with cancer, it was about 5.6%. Those with hypertension, it was about 6%, but about 17% of people who were infected had hypertension. So it seems to be a risk factor for getting the infection. About 6.3% case fatality rate for those with chronic lung disease, such as what we call chronic obstructive lung disease or COPD. About 7.3% with diabetes mellitus, and about 10% with known cardiovascular problems. There are potential treatments that are available that early on investigators have seen may be helpful. Now, I have to say the Chinese government, whether you like them or not, they allowed very transparent sharing of data very quickly. And the physicians and scientists in China quickly were able to identify what this virus is, sequence the RNA, and share that with the world scientists. And this has been, without a doubt, the fastest turnaround of treatments, studies, and the development of vaccines, for which human trials of vaccines have already started, which is just mind-boggling if you know how long these usually take with regulatory issues. So what was made well known by our president last week is that very old medications, chloroquine and hydroxychloroquine, medications initially identified as helpful against malaria, and also more recently used for some autoimmune disorders such as rheumatoid arthritis and lupus, have been shown to decrease or inhibit viral replication in lab animals. In an early human case series where people have gotten this, it looks like it may be helpful, but these are very small studies and they're not truly robust blinded studies to show true effect. We need to be cautious, though. These medications do have side effects. They can cause bone marrow suppression, and they can prolong what's called the QT interval on our EKGs, which can increase the risk for some people for sudden cardiac death or fatal arrhythmias. There are some reuse of other medications. One's called lopinavir, another is ritonavir, which are antiviral agents, which has been shown to be effective for HIV, which is another RNA virus. In initial case series, it did not show statistically significant change in outcome, but it was very low numbers and underpowered. Ribavirin is another potential treatment, was been used for some other viral illnesses, which may have some benefit. Interesting, what we've seen in those that got really severe disease in the ICU is that the immune system goes in overdrive and starts to attack the body. One of these immune peptides is something called interleukin that our body makes, and that's one of these interleukins are what give us the muscle aches, the myalgias, and the fevers. And when people get this immune storm, they can give monoclonal antibodies, specifically that targets these modulators, IL-6, and has been shown in early studies that this has been fairly helpful. At the University of Colorado Hospital, our infectious disease doctors, along with the company Gilead, is going to be starting this trial next week, we hope, if the company is able to ship the medications for patients admitted there. So some of the concerns that we as physicians have, and certainly the whole region, initially was in inadequate testing. More and more has come online. The first non-state run testing in our region was actually at Children's Hospital, Colorado. And then other adult hospitals like University were able to come online a little short of a week afterwards. So our testing capability has increased, but we're still not at the point where we can offer testing to any ambulatory person who may have the symptoms, because the tests use a complex system of PCR, and it can take a number of hours to run. One company is coming out with a quicker test similar to the flu test that primary care physicians have in their office, but that's just coming online, and there's a big backlog on that. But that has hampered our ability to, unlike countries like Singapore, where they could really isolate cases and people they may have exposed, to quarantine them early. As you hear all the time on the news, we have inadequate medication and supplies. Interestingly, the medication chloroquine and hydroxychloroquine, as soon as it became known that this may help, the supplies dropped immediately, or people were starting to get prescriptions and take this even if they weren't having symptoms. And so our ability to treat the more severely infected has dropped. I also carry a Wyoming license in addition to Colorado and Montana. And the Wyoming State Medical Board threatened providers not to prescribe this to any asymptomatic people, so their supplies don't dwindle. University hospital pharmacies also stopped providing these to outpatients unless they had needed them for other chronic issues, in order to conserve the amount for the people that get sicker and are admitted to the hospital. You've also heard about our inadequate personal protection equipment, or PPEs. And so what is a concern, in Wuhan, China, there were about 1,300 healthcare workers that became infected, which is 3 times the general population. And if we have inadequate supplies of this PPEs, many of them had been made in China, then we could have a much higher incidence of healthcare workers that get infected. Currently, the two hospitals that I work for here, Children's and University, have adequate stockpiles for the need, and they're going through, possible approaches to reuse them using UV lights to sterilize them, provided that they're not or destroyed or during use. As I mentioned, as you see in New York City on the news, and talking to my colleagues who do what I do in New York, it's a very desperate situation there. There's inadequate hospital beds, ICU beds, and ventilators. And we just started seeing, as of the last 2 days, what I would call a nonlinear increase of COVID-19 patients admitted to at least the university-based hospitals. And what that means is it's starting to become exponential. I hope that will stop, and that's what, it remains to be seen. And also, hospitals in our divisions, like many of you who own businesses, are financially negatively impacted, where our divisions in our hospital is expecting a significant loss of our usual revenue streams as we're not seeing patients in clinic. So if you're interested in helping, a lot of people have been asking. Some important things are such as sewing masks, although just that's for use in the community. But blood donations, our blood supply has gone down as blood drives have gone down. So blood drives through bond fees or the Children's Hospital are actually very important. So I think I will, hopefully I left enough time. I didn't use too much of my time, and I wanted to open it up for questions.
I had a quick question. I'm wondering, thank you first for presenting to us today. It was very informative. I'm wondering if there is a difference in for elderly, and let's just say 65 plus, in the likelihood of being infected versus, if infected, likelihood of death.
Good questions. So we don't know about if over 65, if you have a higher chance of getting the infection. But certainly we do know there's a higher chance of death if you do. We're not totally certain why, but we do believe a lot of it has to do with our immune response and how it changes as we get older. Hence why we think children who normally seem to be vectors in our community because they're always sick, passing on bugs, their immune system is probably revved up and able to handle this much better early on.
Dr. Kay, I just sent you a question that was sent via chat. I sent it to you personally. If you could please, wouldn't mind picking that up, it'd be great.
If you could repeat the question as well so that everybody knows what the answer is pertaining to.
It's under the chat section.
I don't see your question on my screen. So if,
how about this one from Rick Luthold? If
Comorbidities.
Thank you, are being controlled, for instance, blood pressure medications, do you still see higher virus results, 6 to 14%, or would that be lower?
It's a great question, and we don't have that kind of granular information yet because this is still so new to us. I assume in probably about 3 to 6 months we'll have a better assessment of that. And are these people with poorly controlled high blood pressure or just a history of high blood pressure and medications? As we probably heard, there may be a link to certain medications called ACE inhibitors and angiotensin receptor blockers. And that's because this virus gets into cells, both lung cells and the heart muscle, through what's called the ACE2 receptor, of which our ACE inhibitors will work on. We don't know, and we do think that stopping these medications and having severe exacerbation of their hypertension or heart failure would be worse. So it's recommended that you stay on the treatments.
Dr. Kay, there's another question that was submitted by chat here from Andre, and that is that, so we flatten the curve because of the quarantine, but at some point we have to come out of it. What then? And I'm guessing what Andre is kind of talking about a little bit there is, it's the virus is still going to be out there, and does that mean we all still kind of get it, but it's less urgent, or maybe you can comment on that?
It's a great question, and it's something that our epidemiologists at the School of Medicine were talking about on one of our grand rounds yesterday. We don't know. We are not sure how to come out of isolation safely. We don't know if it's going to die down like influenza and other respiratory viruses would do, or if we stop isolation 4 weeks from now, 6 weeks from now, are we going to have a resurge? And that's a concern. We just don't know that. And we're really looking towards our colleagues, particularly in China, Italy, Northern Italy mainly, and Spain, who have been hard hit, to really see what happens there, since they've got about a 4 to 6 week time lead before us.
I'm not on the screen, but I have a question. What are the risks in delivery that you get from a grocery store, and what kind of precautions can you take in order to ensure that you can be safe?
That's a really great and important question. I would think, since grocery stores are where most of us still need to go to get supplies, it is also probably one of the most likely places where now we can contract the virus. So I saw a very good video created by a family physician in Michigan earlier this week, which gave some recommendations for how to clean food products brought into your house to try to minimize the chance that you catch it, and very careful hand hygiene, where you wash your hands after touching these for up to 20 seconds or no less than 20 seconds. Another option that my family and I have discussed is having non-perishables from the grocery store that we leave in our garage for about 3 days. We would still clean these, particularly the cardboard boxes, but the viral count we expect to be extraordinarily low and much safer at that time.
Hi all, I am going to take over moderating these questions. If you have a question, please use the raise hand feature under participants, or you can put it in the chat box. Carter Sales, if you want to unmute yourself and ask your question.
Dr.
We can't
Kay,
hear you, Carter.
we have a box of gloves and some masks.
My,
We don't know what to do with
my
them.
Rotary meeting
Where do we take?
video call. No, it's okay. It's fine. They're asking.
I would say you can contact any of our regional hospitals, University of Hospital or Children's Hospital, and they would be very much appreciated as our stockpiles may go down.
Thank you.
Another question is from Rich Spong. Is there a difference in juvenile and adult onset diabetes, and is weight a factor?
So we don't know if juvenile, otherwise known as type 1 diabetes, versus adult onset called type 2 diabetes, if there's a difference in risk. We just know that from the earlier studies, the presence of diabetes was a risk. And what was the second part of that question?
And is weight a factor?
Well, weight's going to be a factor because with increased weight, obesity, you have a higher chance of having either diabetes or hypertension. It can also cause some restrictive lung problems. So weight hasn't been identified so much, but the chances that you have any of those comorbidities is much higher.
Carter, go ahead and type your question. We couldn't hear you. Another question from Mike Deneen. What are the chances of a second surge during the fall months? And what can we anticipate from mutations?
That's a really hard question. We don't know. We're certainly very worried about the surge, the second surge coming in the fall. And again, we're going to have our best epidemiologists are looking into that, and it's certainly a concern. Hopefully, we'll have more stockpiles of medications that we can treat people early, prevent infections, and identify things earlier, have more personal protective equipment so that the surge wouldn't be as bad as this one, but it is a worry. We likely won't have vaccines for about 9 months available to the general population. So a second surge in the fall is a concern.
Part of which was answered, but from Doug McLemore, after the curve is flattened, is the only remedy to renormalization of life is a vaccine or concomitant medications?
Yeah, great question. It was estimated by experts in this Boston consortium that I saw a webinar on 2 weeks ago, that the only way for this to go back to normal without a vaccine is if about 30 to 50% of the population gets infected and hence develops immunity. The concern is if 1% of those or 2% will die. So the concern is that we prevent that as much as possible and then develop the adequate vaccine.
Brian Sweet, go ahead and unmute yourself and ask your question.
Yes, Dr. Kay, I apologize if you already said this, but I'm curious, and I've heard that weather is a factor in terms of reducing the spread of the virus. You know, heat maybe is better at killing it. I thought maybe you could address that for a second.
It's not clear yet. It's hoped. So this coronavirus, even though this specific coronavirus called COVID-19, or otherwise known as SARS-CoV-2, is a cousin to other coronaviruses, of which many of us have likely had cold-like symptoms in the past. And the other coronaviruses were more susceptible to the differences in temperature and perhaps humidity, making its ability to stay functional longer less possible in the warmer weather. And we do think that a lot of ultraviolet rays will kill the virus. So we're hopeful, but it remains to be seen.
As more ventilators are made available, will there be a shortage of trained professionals to operate the ventilators?
That's a question I have to think of at different levels. So at a regional level, I'll take first. We're told that we're very fortunate. Of the frontline folks that care for providers, both National Jewish Hospital, which works in conjunction with St. Joseph's, as well as University of Colorado Hospital, are always considered two of the country's best pulmonary divisions, and hence that means we have a lot of them. So our plans at university are adequate for the short run to have adequate, at least physicians. Certainly we worry about our nurses, staff that are really on the front line, and the respiratory therapists as well. So we don't know. We're developing contingency plans in our hospitals for this, and it remains to be seen as the surge hits us in another week to week and a half. We hope so. Certainly New York doesn't. And in New York, they're asking medical students to graduate early and start staffing, as well as many physicians coming out of retirement to help, even though those physicians are at higher risk because of their age.
Should we use masks when out walking?
I don't want to go against what our state is going to be saying, and this changes every 12 hours. What masks do is it decreases the amount of aerosolized virus that an infected person would spread into the area. It's not going to protect you, but if you are an asymptomatic carrier, it will decrease the likelihood that you'll infect somebody else. So it's that balancing act between adequate masks for people to wear in public and what their benefit is. If folks have any homemade masks made out of cloth material, which may not really stop the viruses, but decreases the amount of particles spewed into the air, that may be helpful. So stay tuned to what our state and local agencies recommend.
We'll do two more questions before we run out of time. So Thomas Langino, are recovered patients expected to have immunity, and for how long?
You guys are asking really good questions. We don't know yet. Other coronaviruses, the immune response does not tend to be as great as, let's say, the pneumonia vaccine, that you get that every 10 years for those that it's recommended for. We expect it to be more similar to the flu vaccine, where you need to get annual boosters, but we don't know yet. We've not looked at the serology of those that have gotten infected and recovered and what their immune response long-term is, because we've just identified this since January.
And last question, is it best to pick up groceries or have them delivered by omnibus?
I would have to, this is a personal response. I would have to say, if you can have them delivered, it's probably better, because this way you're going to be exposed to less surfaces. But if your delivery person is infected, that's bringing it to your house. So there's no great answer. You can take precautions, washing your hands, washing the supplies, the groceries, as carefully as possible. So I don't know. My family, personally, we're getting our groceries delivered tomorrow. Oh no, the grocery stores are not giving us the option as much. So we are picking up our pre-ordered groceries tomorrow at a specific time.
Very good. Lauren, is that our last question that was?
It was.
Okay.
Jim, I just want to say to the doctor that I personally feel, and I know that my Rotarian colleagues, respected colleagues, feel the same way. Kindly tell your colleagues that we are deeply grateful to you and to all those people in the health care business, especially nurses and doctors who take care of us, and we are deeply, deeply gratitude to you. And we hope And we pray that all of you stay safe and healthy.
Thank you very much for your kind words.
Thank you, Ved. And that's following up on that, I just put into the chat room a link and I titled it UC Health Doctors Day, which was on Monday. And I didn't notice this getting a lot of publicity out there specifically about it, or maybe I just missed 1 day of news coverage. But this last Monday was Doctors Day. And if you know a doctor who's on the front lines, or somebody who's involved in this, or somebody who's really affected by out there as a healthcare provider, there's a link there where you can click and leave a message to folks specifically in the UC Health Hospital, the health system there, and communicate to them exactly what Ved was just saying about our appreciation for what all of the doctors out there and the healthcare providers are doing right now, putting themselves at risk for the benefit of us. So there's more information there if you want to look at that, everybody. Dr. Joeseph Kay, thank you very much for speaking to us today. A lot of data there, a lot of insight, and a lot of questions as well that we have and that you have as this goes forward. And obviously it's very timely for us to talk to us today, and we really appreciate your time. I'm sure that you're busy with lots of people with questions. As our Rotary Club always does, we are making a donation to Polio Plus, which is a Rotary cause to eradicate polio in the world. And in gratitude for you speaking today, 100 children will receive the vaccine to prevent them from getting polio in the future. And so that's and thanks for you being with us. We'll do that in your name today. So thank you very much.
Thank you.
Thank you.
And I'm sure if we were in front of the crowd as usual in person, you would be hearing a loud round of ovation for gratitude to speaking today, and a little different online, but know that we're clapping and appreciate your time. Wrapping things up here, next week's program, we have another discussion coming to us from a doctor, which with a little bit of a different perspective, which should be very interesting. That will be held at the same time as this one at our usual time on Thursday.